You know when you're trying to take a picture in the dark with an older camera, you press the button, that blinding flash goes off, and then you just have to wait.
Right, the mechanical pause. I mean, the system is completely locked up and you're temporarily frozen out of taking another picture.
Exactly. And you're just mashing the button, but nothing happens because that little indicator light is still blinking. The flash is recharging.
Which takes time.
Yeah, and during that waiting period, the camera is basically useless. It's totally vulnerable, and you're definitely going to miss whatever happens next.
Hmm.
Which brings us to the mission of today's deep dive.
A very critical mission, honestly.
Today, we are decoding one of the most terrifying bright red computer alerts that doctors and pharmacists see on a daily basis. The warning for QT prolongation.
It is a warning that pops up on medical screens constantly. I mean, if a provider were to blindly follow the computer's panic every single time, they'd be terrified to prescribe almost anything.
Right? Nobody would ever get their meds.
Mm.
So our goal is to help you, the listener, understand the actual electrical mechanics of your heart.
To really see what's happening under the hood.
Yeah. We want you to be able to distinguish between a true drop-dead medical emergency and just a hyper-cautious regulatory warning.
Which is a huge distinction.
Totally. We're going to look at how medical professionals actually evaluate the real-world risk when they're prescribing everyday medications you've probably taken, things like antibiotics and antidepressants.
The stuff sitting in your medicine cabinet right now.
Exactly. Okay, let's unpack this, starting with the heartbeat itself. If the heart is like that camera flash, what exactly is the QT interval measuring?
Well, to understand that, we have to look at the electrocardiogram, the EKG.
The classic jagged line on the monitor.
Right. When you see that classic green line tracing across a hospital monitor, you are looking at three main waves of electricity. The P wave, the QRS complex, and the T wave.
Ah, the classic medical alphabet soup.
Yeah.
But what do those letters actually map to in the muscle, like physically?
So think of it sequentially. The P wave is just the small top chambers of the heart squeezing to push blood down.
Okay, top chamber squeeze.
Then comes the really big spike, which is the QRS complex. That is the main event.
The big one.
Right. In medical terms, it's called ventricular depolarization. It's the massive electrical signal that commands the main pumping chambers of your heart to forcefully squeeze and send blood out to your entire body.
Oh, so that is the camera flash going off?
Exactly, the big burst of energy. And then comes the T wave, which represents repolarization.
Repolarization.
Right, that is the camera flash recharging. So the QT interval is simply the measurement of time from the very beginning of that big QRS spike to the very end of the T wave.
Okay, so it's the total time it takes for the lower chambers to fire and then completely reset themselves chemically for the next beat.
You've got it. That's exactly it.
So QT prolongation simply means that the recharging phase is dragging on for too long.
Right.
The blinking light on the camera is taking forever to go solid.
Precisely. And just like the camera is mechanically useless while it's recharging, the heart muscle is electrically unstable while it is waiting to finish repolarizing.
Unstable how?
Well, if that ventricle sits idle for too long, the electrical grid becomes highly vulnerable. It can go rogue and trigger a catastrophic arrhythmia.
Wow, okay. So if a drug is setting off an alarm, we first need to know what part of the heart it's attacking. And the sources say this rogue arrhythmia is basically the monster hiding under the bed in all these medical alerts.
It absolutely is.
If that QT interval drags on, we are risking a very specific, very fatal event called Torsades de Pointe, which I have to say sounds almost elegant, honestly.
Yeah, it's French. Literally translated, it means twisting of points.
Twisting of points.
Right, though in American hospitals, you'll usually just hear it pronounced without the S, like Torsade point, or just abbreviated as TDP.
TDP, got it.
It is a form of polymorphic ventricular tachycardia.
Wait, polymorphic, meaning it's like changing shapes on the screen?
Yes, and that perfectly explains the twisting of points name. Normally, an EKG has a flat, calm baseline.
The isoelectric line, right?
Exactly, with regular uniform spikes that all look identical. But in Torsades, the electrical signal goes totally chaotic.
How so?
The spikes grow large, then small, then large again, constantly changing amplitude and direction. It looks exactly like a twisted party streamer wrapping around that flat baseline.
Wow. Sounds like a pretty disastrous party. Inside the chest, what is actually physically happening to the heart when the electrical signal looks like a twisted streamer?
While the heart is beating incredibly fast and completely out of sync, the ventricles are just quivering and spasming.
Just completely spasming.
Yeah, and because they are beating so rapidly and erratically, the chambers don't actually have time to relax and fill with blood between beats.
Oh, I see. So it's pumping, but it's pumping empty.
Exactly. No blood is moving out to the brain or the body. The patient rapidly loses their pulse, and if they aren't shocked out of it with a defibrillator, it leads directly to cardiac arrest.
So it's fatal.
It is a fatal event.
Okay, well, that definitely establishes the stakes. I completely understand why the computer alerts are screaming.
They have a good reason to.
But looking at the source material, the alerts don't just talk about the QT interval. They talk about the QTC.
Ah, yeah.
There's a little C at the end for corrected. And apparently, this correction uses complex mathematical models, like the Pazet formula, to adjust the number based on the patient's heart rate.
Right. The Pazet formula is very common.
But logically, if your heart beats faster, shouldn't the QT interval naturally get shorter? I mean, if the heart is working faster, the recharge time has to speed up to keep pace.
You would think so.
Right. So why do we need a complex math equation just to correct it if the body is already doing it naturally?
What's fascinating here is that you've hit on the exact physiological reality.
Oh, really?
Yeah. The interval absolutely naturally shortens when your heart rate speeds up, and it elongates when your heart rate slows down.
Okay, so the math isn't fixing a biological problem.
No, the mathematical correction isn't fixing a biological mistake, it's fixing a communication problem between doctors.
Wait, how so?
Well, it exists specifically to normalize the clinical language. Let's say your heart is beating at 60 beats per minute, and mine is racing at 100 beats per minute.
Okay.
Our raw QT intervals are going to look vastly different just based on the speed alone. By applying that mathematical correction, we standardize everything to a universal baseline. It allows a clinician to look at a single number and instantly know if it's dangerous, regardless of how fast the patient's heart happens to be beating at that exact second.
So it basically levels the playing field so everyone is speaking the exact same language.
Exactly.
Well, what are the actual numbers we're looking for on this standardized playing field?
Generally, a normal QTC is between 400 and 440 milliseconds.
400 to 440.
Right. There's a bit of a gray area, and then prolonged is typically considered anything around 470 to 480 milliseconds.
Okay, so a jump of 30 or 40 milliseconds is prolonged.
Yeah, and there are slight natural variations, too. Men tend to have slightly shorter intervals than women, for instance.
Sure. But where is the actual danger zone? Like, where do we start worrying about the twisted party streamer?
The universal danger zone for Torsades de Pointe is a QTC over 500 milliseconds, or, alternatively, a massive jump from a patient's normal baseline.
What's considered massive?
If a patient's QTC suddenly jumps by 15 to 20%, which usually translates to an addition of about 60 milliseconds, that is a massive clinical red flag.
Okay, so a jump of 60 milliseconds is where clinicians start getting really sweaty.
Very much so.
But this creates a massive disconnect when we look at the FDA guidelines in the sources.
Oh, the FDA guidelines.
Right. The FDA has guidance for drug manufacturers developing new medications.
Yeah.
If a phase 3 trial shows that a new drug prolongs the QTC by a mean of just 5 milliseconds, the FDA starts to pair.
Yes, they do.
Over 5 milliseconds. And it can end up as a stern warning in the package insert. So what does this all mean? Clinicians don't panic until the interval jumps by 60 milliseconds, but the FDA is throwing warning labels on drugs that cause a 5 millisecond change.
It's a huge gap.
That's literally 5 thousandths of a second. It feels like setting off a 5-alarm fire response because someone slightly burnt a piece of toast.
It is extremely conservative. From a regulatory standpoint, they are casting the widest safety net possible to catch any drug that might affect the electrical system.
Which makes sense for the FDA.
Right. But the real-world impact of that caution, when it meets clinical practice, is incredibly frustrating for pharmacists and doctors.
I can imagine. The sources actually mention a highly common anti-nausea medication called ondansetron, widely known as Zofran, as a perfect example of this friction.
Oh, ondansetron is a classic case. The QT prolongation risk with it is heavily dose-dependent.
Okay, dose-dependent.
Meaning, if you give a patient a standard 8 milligram dose, it causes about a 6 millisecond change in the QTC.
Which is clinically basically nothing, but it trips that FDA 5 millisecond wire.
Exactly. But if you give a massive 32 milligram IV dose, that change jumps up to around 20 milliseconds.
Still not in the 60 millisecond danger zone, but it's getting much warmer.
Getting warmer, yeah. The problem is that in an ICU, a provider might order a very low, very safe 4 milligram dose for a nauseous patient.
Right.
But the hospital computer system isn't smart enough to read the nuance of the dose. It just sees the name on Dancitron, accesses the FDA warning based on the 32 milligram high dose data, and throws a massive screen blocking alert warning the doctor about fatal arrhythmias.
That is the definition of alert fatigue. I mean, if the computer screams wolf every time someone gets a tiny dose of anti-nausea meds, people are going to start ignoring the alerts entirely.
That's the real danger.
And that seems dangerous because if we ignore the boy crying wolf, we might miss the actual wolves.
Oh, absolutely. There are drugs that absolutely deserve the panic.
Yeah, when I was looking through the source list of everyday drugs, I was genuinely surprised by some of the culprits.
There are a few surprises on there.
There's a database called credible.meds.org that categorizes over 200 drugs into known risk, possible risk, and conditional risk for Torsades.
It's a great resource.
And the undeniable heavy hitters are a specific group of heart medications called Class 3 antiarrhythmics. Drugs like dofetilide, dronedorone, and Sotalol.
Yes, those are notorious. They are so known for causing massive QT prolongation that you usually can't even start a patient on them at home.
Oh, wow.
Yeah, they have to be admitted to the hospital, hooked up to continuous EKG monitors, and checked after every single dose.
That's intense.
Honestly, they are kept in the hospital so that if they do go into Torsades, a medical team is physically standing right there to shock their heart back into a normal rhythm.
Talk about high stakes. But it's not just intense heart medications on that credible meds list. Standard antibiotics like macrolides, which includes the incredibly common Z-Pak, are known risks.
Yep, the Z-Pak is on there.
Quinolone antibiotics like levofloxacin too. And the psych meds really stood out to me. Older antipsychotics like Haldol and specific SSRI antidepressants like citalopram and escitalopram, brand names Celexa and Lexapro.
The SSRIs are fascinating because the risk isn't uniform across the class. Lexapro is uniquely implicated, especially if a patient overdoses on it.
Really?
Yeah, whereas an SSRI like sertraline or Zoloft is considered much safer from a QT perspective.
Here's where it gets really interesting, though. As I was comparing the drugs on that list, I noticed a glaring contradiction.
Oh. What did you spot?
Well, we just established that Class 3 antiarrhythmics are the absolute worst offenders.
They are.
But there's another Class 3 antiarrhythmic called amiodarone. It substantially prolongs the QTC, just like its peers. But the data shows its actual risk of triggering Torsades de Pointe is remarkably low.
Yes, the amiodarone anomaly.
Right. Why does amiodarone get a free pass when the others in its exact same class are so deadly?
It is an anomaly that has puzzled cardiologists for years. To understand why it's safer, we have to look at the mechanism of the recharge. We said earlier that the T wave is the heart resetting.
Right, the camera flash recharging.
At a cellular level, that reset is primarily driven by potassium rushing out of the heart cells. When potassium leaves, it resets the electrical charge.
Okay, potassium leaves, electricity resets.
Pure class 3 drugs block those potassium channels. The potassium can't leave, so the recharge drags on, leaving the heart vulnerable to rogue beats.
So amiodarone blocks potassium too, which explains the long QT on the screen.
Yeah.
But what else is it doing?
Amiodarone is a multitasker. It doesn't just block potassium, it also blocks sodium channels, calcium channels, and beta receptors.
Oh, wow. All of them.
By blocking all of those extra pathways simultaneously, it broadly dampens the heart's overall excitability. It essentially acts as a built-in safety mechanism.
Built-in safety. I love that.
Right. It prolongs the QT interval, but it suppresses the heart's ability to generate those jittery, rogue early beats that actually kick off the twisting arrhythmia.
That makes a lot of sense. So the properties of the drug on the screen really only tell us how big the spark is.
Exactly.
But a spark doesn't matter much if the tinder is wet. Or conversely, if the patient's body is bone-dry tinder, even a tiny spark from a low-risk drug could be disastrous.
That is an excellent way to frame it. The drug is the spark, the patient is the tinder.
And looking at the sources, the patient factors that dry out that tinder seem extensive. Obviously, low potassium, hypokalemia, because if you don't have enough potassium to rush out of the cells, the reset drags.
Right.
But there's also older age, being female, heart failure, and active cardiac ischemia, meaning they're actively having heart attack.
Even systemic infections like sepsis dry out the tinder.
Sepsis too, really?
Yeah. Hospital pharmacists actually synthesize all these physiological variables to calculate exactly how dry the tinder is using something called the Tisdale risk score.
The Tisdale risk score.
It assigns points to all those risk factors. If a hospitalized patient scores an 11 or higher, they are officially in the high-risk category for QT prolongation.
Okay. Another major risk factor jumped out at me from the list. Bradycardia? A
Yeah.
slow heart rate?
Yes.
If a slow heart rate leaves the ventricles sitting idle and vulnerable for longer,
Yeah.
is that why one of the emergency treatments for torsades is to literally use a pacemaker to force the heart to beat faster? Are they essentially just outrunning the arrhythmia?
You are literally outrunning it.
Wow.
When you pace the heart and force it to beat faster, you drastically shorten the QT interval. You are shrinking the window of vulnerability, giving the rogue electrical signals less time to take over.
That is brilliant.
It is. But if we connect this to the bigger picture, while outrunning the arrhythmia is a great emergency fix, preventing it using tools like the Tisdale score is incredibly complex. The score has severe limitations.
Because it's just a calculator.
Exactly.
Yeah.
And most importantly, it only predicts the likelihood of QT prolongation. It does not predict the actual occurrence of torsades de points.
Just like the amiodarone anomaly.
Right. As we saw with amiodarone, you can have a prolonged QT without the fatal arrhythmia. Furthermore, the Tisdale score completely ignores a patient's kidney function, it doesn't account for magnesium levels, and it doesn't factor in complex drug-to-drug interactions.
Wait, it doesn't account for drug interactions at all?
No. For example, if drug A stops the liver from metabolizing drug B, causing drug B to build up to toxic levels in the blood, the score misses that.
Wow. So we have so many moving variables here. Inaccurate computer alerts, dose-dependent drugs, a risk score that ignores the kidneys, and complex patient histories.
It's a lot to juggle.
To see how a clinician actually solves this puzzle in real time, I want to look at a real-world case study from the sources. Let's say you run an outpatient pharmacy.
Yeah.
A 50-year-old male comes in. He takes citalopram, Lexapro, chronically for his mood.
Okay.
He just went to urgent care for a bad cough, and they prescribed him a 5-day azithromycin Z-Pack.
A scenario that happens thousands of times a day.
Right. The pharmacist types it in, and immediately the system throws a red alert. Drug interaction, increased risk of QTC prolongation. Both of these drugs are on the Credible Meds known risk list.
Yep, they definitely are.
What is the cognitive algorithm here? Like, what is step one?
Step one, as always, is the underlying EKG actually accurate?
Okay.
Now, in an outpatient pharmacy, you don't have an EKG in front of you. But in a hospital, you'd look at the reading. The computer spits out a QTC number, but you cannot blindly trust the computer's math.
Because the Bazette formula can be thrown off.
Garbage in, garbage out. The QTC is completely unreliable if the patient has underlying structural or rhythm issues.
Like what?
For example, a bundle branch block. Think of a bundle branch block like a traffic jam on the heart's internal highway.
Okay, a traffic jam.
The electrical signal has to take back roads, which makes the QRS spike, the big squeeze, look much wider on the screen.
Right.
Since the QT interval measures from the start of that QRS, an artificially wide QRS makes the whole QT interval look artificially long.
Oh, that makes perfect mechanical sense. What about irregular heartbeats?
That's the biggest confounding factor. If a patient has atrial fibrillation, or AFib, their heart rate is irregularly irregular.
Irregularly irregular.
Yes.
Yeah.
It's constantly shifting beat to beat. 80 beats per minute, then 110, then 75.
Wow, all over the place.
Exactly. Since the Bazette formula uses heart rate to calculate the correction, a constantly shifting heart rate completely breaks the math. You can't calculate a standard average when there is no steady state.
So step one is confirming you actually have a valid measurement.
Always.
Well, for our 50-year-old guy, let's assume he has a normal heart rhythm. The imaginary EKG is accurate. We have 2 drugs with a known risk. My instinct as a patient reading that would be, hey, let's just play it safe and swap the antibiotic for something else.
Many people would think that.
Right. But based on the numbers, the Lexapro adds maybe 5 to 10 milliseconds, and the Z-Pack adds maybe 5 milliseconds.
Are we risking trading a minor issue for a major one by swapping? You absolutely are. You always have to weigh the alternatives. This isn't just about avoiding QT prolongation at all costs. It's about holistic patient care.
Right, because the alternative antibiotic might have its own severe baggage.
Exactly. We constantly prescribe drugs with known life-threatening risks because the statistical probability is infinitesimally low.
Do you have an example?
Look at lisinopril, one of the most common blood pressure medications in the world. It carries a 0.1% risk of causing angioedema, a severe, potentially fatal swelling of the throat and airways.
Terrifying.
Yet, we prescribe it safely every single day.
So for this 50-year-old male, what's the final verdict?
He's male, which is naturally lower risk. He's
Hmm.
relatively young. Assuming his uncalculated Tisdale score is low and there are no other interacting drugs boosting the blood concentrations of the Lexapro or the Z-Pak, the risk of actually going into Torsades de Pointe is incredibly, incredibly low. Swapping to a different antibiotic that might be less effective for his specific lung infection or might give him horrific gastrointestinal side effects actually does more harm than good. The clinical benefit of treating the infection with the Z-Pak far outweighs the microscopic risk of the arrhythmia.
So the clinician decides the risk is low, but acknowledges that it is not absolute zero.
Right.
The patients still have to go home with these pills. That seems like the ultimate challenge of outpatient medicine. In the hospital, you can just hook them up to an EKG monitor and watch them.
Which is easy.
Right, but outpatient, they are on their own. If you hand me a pill bottle and say, hey, just a heads up, watch out for a fatal twisting ventricular arrhythmia, I guarantee you I am throwing that pill bottle directly into the trash.
Which completely defeats the purpose of you seeking medical care for the cough. You have to empower the patient to monitor their health without paralyzing them with fear.
How do you frame that for you, the listener, if you're picking up this exact prescription? What should you actually be looking for in your own body?
We advise patients to watch for 3 very specific, actionable symptoms: unexplained dizziness, feeling sudden, intense palpitations in your chest, or syncope, which is fainting.
Why those 3 specifically?
Because those symptoms often represent a self-terminating episode of torsades. Your heart might slip into that chaotic, twisting rhythm for just a few seconds, making you feel dizzy because blood isn't reaching your brain, or causing you to pass out and then pop back into a normal rhythm on its own.
Oh, I see. It gives the patient a concrete physical sensation to watch for, rather than just abstract anxiety about a heart monitor they don't have.
Exactly.
If you feel dizzy or faint, you stop the medication and you call your doctor. It's practical, it's safe, and it doesn't induce panic.
It's all about filtering the noise from the signal.
And that brings me to a final thought I want to leave you, the listener, to ponder today as consumer technology rapidly advances.
The landscape is definitely changing.
We talked earlier about how irregular heartbeats, like AFib, completely ruin the math for calculating the QTC interval. You need a perfect, steady baseline for the hospital computers to even have a chance at getting it right.
You do.
But right now, millions of us are walking around with consumer wearable tech, smartwatches on our wrists, that are beginning to attempt to measure these complex electrical intervals in real time. Not lying perfectly still in a hospital bed, but running for the bus, drinking too much coffee, having a stressful meeting.
It's a totally different environment.
Right. If the highly sophisticated hospital algorithms struggle to differentiate a safe 4-milligram dose from a 32-milligram dose, what happens to the messy data coming off our wrists?
It is going to be a massive influx of incredibly noisy data into the medical system.
Will a constant stream of inaccurate QTC alerts from our smartwatches cause a massive epidemic of medical anxiety, sending thousands of people to the ER for a camera flash that's just taken a normal amount of time to recharge?
That's a huge worry.
Or will the algorithms eventually get smart enough to filter out the noise, becoming even better than our current hospital systems at catching the real danger before it strikes? Something to keep an eye on, and maybe check your pulse on next time your wrist buzzes. Until next time, stay curious.